And conflict of interest. Question has a patent by Universal Health Network, and I have recommended it. So the outline is on adverse events of patients with and second component is
¿No se puede poner sin los settings del costado?
Sí, tiene que mover el punto. Si mueves,
of sleep apnea is increasing obesity in the world at the present.
La dinámica de visual.
He was diagnosed with hypertension at the age of 20. And then he died.
Dice que tiene mucho ruido de allá. Seguro que el único micrófono que está abierto es el de ella, porque tiene mucho ruido, no puede escuchar bien. Yo tengo que estar en todo silenciado menos ella.
He was handsome when winning the war, and then at the time of defeat.
He was obese, and he was probably also suffering from sleep apnea. So the prevalence of sleep apnea with an apnea index of more than 13 events per hour is about 11%.
Seguro que la única es porque me dice que tiene mucho ruido. Dice que tiene mucho ruido de allá. A ver.
Esta le corto, Mario. Eso somos nosotros, ¿eh?
Sí, que nos corta.
Estamos muteados. Cortamos nosotros el sonido acá.
13-year-old boy who has general anesthesia, history of sleep difficulty, morbidly obese. Post-op after surgery, he was discharged home, and then on his way home, he ate a Big Mac. He slept on a sofa on the way home, and his parents could not rouse him and have to call 911 emergency. Patient suffer from permanent brain damage. And we have cases in North America at present. And this is a case we have in our hospital of a 62-year-old morbidly obese woman who actually have removal of hardware of the forearm. And she actually then received PCA morphine. As a result, at about 10 or 11 o'clock at night, she suffered a respiratory arrest after receiving 21 milligrams of morphine. She was admitted to ICU. She was resuscitated. The next day, we did a sleep study on her. Her apnea-hypopnea index was 79. That means she stopped breathing 79 times per hour, every hour. In Nova Scotia, this is a 40-year-old man, apparently healthy for hand surgery. Patient had pain at 12 a.m., received IM morphine. At 4 a.m. was found to have arrested anoxic brain damage. Seattle, similarly, a 42-year-old male ACL repair at home the next day. When the spouse came home from work, patient has already died. A 52-year-old female, shoulder surgery, sleep apnea, and actually went home. The next day, the family found her dead in bed about 10 o'clock. In England, abdominal hysterectomy, sleep apnea, monitored in ICU for the first night and step-down unit the second night, arrest in ward on the third night. So the RCMP, which is the police in Canada, will be coming after you. So what is the evidence in the literature? Staffos actually look at national surgical sample of millions of patients, and actually he found that with general surgery and orthopedic patients, there is increase in aspirations, ARDS, and re-intubation in the patients that have sleep apnea, which is shown in red. In the non-sleep apnea patient, which is shown in blue here, they do not have such a higher incidence of complications. So also in the recent literature, using national surgical sample and premier database, looking at millions of patients, they have found that sleep apnea increased risk of emergent re-intubation, increase in ventilatory support in the post-op period, increased risk of atrial fibrillation. Pulmonary complication is twofold increase. Cardiac complication is 60% higher, and they consume more economic resources, longer length of stay. And also, they show that sleep apnea increase in hospital death rate. In the national surgical sample of 250,000 patients doing revision joint arthroplasty of hip and knee, there is increase in hospital mortality. The death rate is almost twofold versus those who have no sleep apnea. And also it has been shown recently that sleep apnea is associated with post-op delirium. Now, are sleep apnea an increased risk of peri-op complication? Can we, as anesthesiologists, prevent the peri-op complication? So, anesthesia risk of sleep apnea patients due to sleep apnea by itself, but morbid obesity will contribute to it, plus the comorbidities. The three factors all contribute to anesthesia risk. Malignant hypothermia was a big issue in the 60s or 70s. By asking a past history of anesthesia, asking a family history of anesthesia, and rule out any MH susceptible patients, and we manage accordingly, and we give dantrolene if MH is actually happened. It is no longer an issue now. Can we do the same for sleep apnea? And I will show you. Can we ask whether the patient have any symptoms and signs of sleep apnea? Do they have a family history of sleep apnea? Because if they have a family history of sleep apnea, they are 2 times more likely to suffer from sleep apnea from themselves. If we rule out the sleep apnea likely patient, or we manage according to specific protocol, or we give CPAP, can we change? So there are some clinical conundrum. Many patients with untreated sleep apnea, undiagnosed sleep apnea, they are having surgery every day. Why do not more patients have death or increased post-op complications? So the questions to ask are, which sleep apnea patients are at risk? Which type of surgery? Which apnea-hypopnea index? Which oxygen desaturation? And how about, is it because we give opioid, we actually prevent the arousal response of the patient so that they have the respiratory depression and cause sleep apnea? So I will go to recognition of sleep apnea, which is my next topic. There are different types: known, unknown, treated, and untreated. So even patients who are diagnosed with sleep apnea, and we actually look at our data of over 100 patients who actually have sleep apnea as a diagnosis. But 15% of them were not recognized by the anesthesiologist because first, they did not ask the question. Second, they did not write this on the anesthesia pre-op record. So they missed the patient having sleep apnea. And undiagnosed sleep apnea is very common in the general populations. 82% and 93% women with moderate to significant sleep apnea are not diagnosed. And the prevalence of undiagnosed sleep apnea is actually very high in surgical patients. There are 2 studies showing 60 to 70% of patients coming with undiagnosed sleep apnea every day. And the diagnosed sleep apnea, even if they are diagnosed, over half of the patients are not compliant with CPAP. So how do we identify the patients? What are the symptoms? There is a STOP questionnaire and the STOP bang questionnaires. So first is snoring. The snoring has to be loud enough, over 50 decibel. So we have to ask the right question. Do you snore loudly, loud enough to be heard through closed doors? Or do you snore loudly that your dead partner elbows you at night time? Are you tired, fatigued, or sleepy during the daytime? And they fall asleep watching TV, driving, and at work. And sometimes the patients are depressed and fatigued without knowing that they have sleep apnea. Anybody observe you stop breathing or choking or gasping during your sleep? And do you have a history of high blood pressure? Are you obese, BMI over 35? Are you over 50 years old? Is your neck collar 17 inches for male and 16 inches for female? And gender male. Out of these 8 questions, 3 out of 8 questions positive, the patients probably are at risk for sleep apnea. So there are different types of sleep apnea, mild, moderate, and significant, depends on the number. So for AHI more than 5, and you can see the sensitivity and specificity is here. So what does it mean? Sensitivity is null. High sensitivity, negative test, you can rule out sleep apnea. So if the patient scores 0 to 2, it's unlikely that they have sleep apnea. And also, when we did the stop bang, we did not equally weight everything. We actually just give weight of 1, but they are not equally weighted. So we can see that with BMI, with neck circumference, and male gender is more significant and more predictive that the patient has sleep apnea versus age, which is less specific. So if the person is STOP positive with BMI 35, 84% positive predictive value. STOP positive with a big neck, 89%. STOP positive with age, male, BMI, almost 100%. The higher the score of stop bang, the more likely the person will suffer from sleep apnea. And a stop bang score of 5, 74% specific, 6, about 88%, 96%, about 7. So what does it mean? It's actually spin, high specificity, a positive test, you rule in sleep apnea. So essentially, a score stop bang of 5, a 5-fold increase in risk of sleep apnea compared with a score of 0 to 2. And if you have a stop bang score of 6, it's a 6-fold increase in risk compared with a stop bang score of 0 to 2. And a score of 7 is a 7-fold increase compared with a score of 0 to 2. So most patients are at low risk of sleep apnea and represented by triangle of stop bang 0 to 2. The intermediate group, which is higher risk, is 3 to 4. And the high risk group is actually smaller in number and represented by stop bang 5 to 8. For the morbidly obese patients, the score is shifted by 1. However, majority of the patients with the morbid obese patient, a small number, 10 to 20%, have obesity hypoventilation syndrome. These are the patients that are most likely to get you into trouble if a bariatric patient comes for surgery. The reasons: sustained nocturnal hypercarbia may elevate the bicarbonate. We have shown and published in CHEST recently that increase in apnea-hypopnea index by 10 events per hour increase the bicarbonate by 0.17 millimole per liter. So essentially, with a stop bang more than 3, 87% sensitive. Sorry, 97. However, with the bicarbonate of 28 is 79% specific. The higher the bicarbonate, the more specific it is, the more likely the patient have sleep apnea. So all the information are at this website, www.stopbang.ca. We have all our publication there, we have our protocol there, and you can go there. With the sleep apnea patients, yes, obese patients would have it. However, Asian population and also some athletes may have it because of the shape of their jaws. And it is very important to recognize the patient that sleep apnea is common. Anesthesiologists and PACU nurses are the airway specialists. We may be the first one to identify patients having sleep apnea. And they can have motor vehicle accident. And also, even if they take sleep cough syrup, they may die because of the codeine in it. So what effect does sleep apnea have on lifespan? American lifespan is about 77 for male and female 84. However, the sleep apnea patient may die 20 years younger. This is the 10-year life survival. And this is the smoker. And this is the mild sleep apnea. And then you can see with the severe sleep apnea, then the lifespan is much worse than a smoker. So what do we do if patients are screened positive? When should we refer our patients? More research is needed. However, the Canadian Thoracic Society said that we should refer the patient if the patient is a driver of a motor, a bus, or school bus. They have critical patients with safety issues, patients who have high risk of sleep apnea with daytime somnolence, patients with high risk of sleep apnea if they have comorbidity. What is it? Resistant hypertension, resistant diabetes, if they have nocturnal angina and congestive heart failure. So we can look at this, and maybe we should refer this patient as a physician. And also, as a sleep physician, if you do 1 year of sleep medicine, you can specialize in it, and you can practice sleep medicine in a clinic form. As anesthesiologist, it's recognized in the USA that you can study just 1 year and certified. So what is the advantages? We look at about 200 of our patients that were referred and were put on CPAP. Actually, these patients require much less medication for their treatment of blood pressure and diabetes, etc. And also, oximetry is a very simple way to diagnose some of the sleep apnea if you don't have polysomnography, the sleep studies. We have shown that oximetry is a very sensitive tool to predict moderate and severe sleep apnea. The vertical axis here is apnea-hypopnea index. The horizontal axis is oxygen desaturation index. And there's very good correlations between oxygen desaturation index and apnea-hypopnea index. So the STOP-BANG questionnaire is very useful to screen obstructive sleep apnea. And it's time to take action, as one death is too many. The undiagnosed sleep apnea patients are the most likely to get us into trouble. And we should ask ourselves, can we do something for sleep apnea instead of having a risk of death or morbidity on our hand? Just like MH, can we screen the patient for sleep apnea? Can we evaluate them, treat them, or put them on CPAP? So thank you very much for your attention.
Muchas gracias, Frances. Una excelente exposición, como siempre. Ahora, Frances nos trajo el problema y ahora va a explicar también en forma contundente qué cosas cada anestesiólogo de cualquier lugar del mundo, haga o no haga anestesia para pacientes obesos mórbidos, debería saber hacer en cada uno de los pacientes que tienen apnea de sueño. So, please.
So I would like to invite you to be at the Society of Anesthesia and Sleep Medicine, which start on October 9th in the afternoon, and October 10th the whole day, just before ASA. And also, this is our website. So I would like to talk about obstructive sleep apnea, what anesthesiologists should do. So actually, for those who come in late, I would like to disclose the information that my research has been supported by various foundations. And also, I do declare a conflict of interest. The Stop Bank has a patent, and the patent belongs to our University Health Network, and I have no personal benefit from the patent. So the outline today is peri-op management of sleep apnea and CPAP treatment. For the portable sleep study, I used the Emblator to do the research. Again, I have no benefit from Emblator. I bought all the Emblator myself. What we did is the surgical patients, whether they have sleep apnea and no sleep apnea, we did the home sleep study with the Emblator, which is a 10-channel, which you can monitor the EEG, ECG, the nasal flow, and the brain activity as well, and the oximetry. And then we watch them pre-op, post-op, night 1, night 3, night 5, and night 7. And these are our results. The post-op sleep architecture. And you can see here, this is sleep efficiency, which means that the patients do not sleep as well on day 1 and day 3. And then for the light sleep, which is stage 1 and stage 2, the light sleep of these patients are increased on day 1 and day 3 post-op. And the deep sleep, which is stage 3 and 4 sleep, they are decreased on night 1 and night 3. And then the REM sleep, which is the rapid non-eye movement sleep, are decreased on night 1 and night 3 and gradually rise back to 5 and 7. I would like to share with you our data on the apnea-hypopnea index, which is the number of episodes of apnea, stop breathing, hypopnea, decrease in amplitude of breathing per hour. So that is the vertical axis, and the horizontal axis are the various nights. And you can see here that non-sleep apnea patients, they are decreased on night 1 and night 3. So even if you don't have sleep apnea, because of the respiratory depression by opioid, they do occur. The mild sleep apnea behave very similar to no OSA patients. For the moderate sleep apnea patient, you can see on night 1 and night 3, the apnea-hypopnea index increase. And for the severe sleep apnea patients, again, there are increases on night 1, night 3, and night 5, but there is wide variations. So in summary, you can see this is the post-op night, pre-op. The mild sleep apnea and the no OSA patients behave in a very similar pattern. For the moderate and severe sleep apnea, they are also very similar. However, I have to warn you, most of the respiratory depression and the desaturation and increase in apnea-hypopnea index actually occur on the first night. But a lot of our patients, they have oxygen, which was given by the surgeons, the anesthesiologists, and the nurses on the first night because they have low oxygen saturation. So it makes their oxygen saturation less, and therefore the apnea-hypopnea index actually not as worse on night 3. On night 3, only 7% of the patients receive oxygen. As a result, those patients actually have the highest oxygen desaturation, the highest apnea-hypopnea index. So a question to ask is, the MI, the death rate, and the pulmonary embolism are the highest on the day 2 and day 3. Is it all related? Now, how about male and female? These are non-sleep apnea patients, and this group is the sleep apnea patients. And the male is in red, and the female is in blue. You can see here the male does worse than female on pre-op night, night 1 and night 3. And how about general anesthesia and regional anesthesia? Again, the general anesthesia is in green, the regional anesthesia is in purple. And this shows that for the GA and regional, the apnea-hypopnea index are very similar. But why is that so? Essentially, this is not a RCT. So the regional anesthesia orthopedic patients that have knees and also hips mostly, and the general anesthesia are the abdominal surgical patients and also the spine patients. And so essentially a lot of the orthopedic patients, they have regional block, their blocks wear off, they still require opioid, and that may be the reason why they have the oxygen desaturation still. And how about positioning? Positioning is important, as is stated this morning. For the position, for the non-supine position, and also the supine positions. The blue is the supine position, and you can see that on day 1 pre-op and also day 3, the apnea-hypopnea index are increased compared with the non-supine position. So what are the factors? There are 3 factors that predict increase in post-op apnea-hypopnea. First, if the person has high pre-op apnea-hypopnea index, an elderly patient, and also the total 72-hour opioid dose, it will be associated with an increase in post-op apnea-hypopnea index. How about central apnea? And there are also 3 factors: higher pre-op central apnea, and also the male sex, and also general anesthesia. They are associated with an increase in post-op central apnea index. For the non-OSA patient, you can see here, these patients do not have apnea or obstructive apnea, and you can see each red dot here, those are the abnormal patients that have very high apnea-hypopnea and oxygen desaturation on night 1 and also night 3. So are these patients that are very sensitive to opioid and cause us trouble? I actually look at 120 of these patients, and we divide them. There are 2 groups. 30 of the patients are the red line. They are the one that actually have increase in apnea-hypopnea on day 1 and day 3. The other 90 patients have no change. So what are the factors? We find that every increase by 5 years and actually will predict increase in apnea-hypopnea index in non-OSA by about 20-something%. And every increase in 10 years elevate the risk by about 60%. And increase in respiratory disturbance index, which is RDI, also increase about 5 events per hour in the pre-op sleep study, will magnify the increase of post-op sleep apnea by about 67%. And if the RDI is increased by 10 events, and also it will increase the risk of post-op apnea by 3-fold. The ASA newsletter, actually Alan Lockwood actually did the ASA closed claim studies. And she reported the majority of the respiratory depression or arrest occurred on the first 24 hours. And the majority of them actually occurred on the first 6 hours. And out of this first 6 hours, the majority of them occur on the first 2 hours when the patients are in the wards. And so what should we do? And we can do that by identifying the patients and then manage the patients and then monitor the patients. So if the patient, we suspect the sleep apnea, if they have low risk stop bank 0 to 2, then routine management. If they are suspected sleep apnea, their high risk score of 5 to 8, then high bicarbonate. And also if they have comorbidity and coming from major elective surgery, yes, then we should consider referral. If no, then maybe practice periop precautions. What are they? Prepare for difficult airway, short-acting anesthetic agents, avoid opioid, full muscle relaxant reversal, extubate in the reverse transdermal position, and also use CPAP. And the other thing is for documented sleep apnea. If it is mild, they may not need CPAP, then no worries. However, if they have moderate or severe sleep apnea, so essentially they should be on pre-op CPAP treatment and again, the periop precautions. So for outpatients, there is the SAMBA guideline, which is published in recently in 2012 anesthesia analgesia. And if there are no OSA, if they have optimized medical condition, require minimal opioid, they are on CPAP, then it is okay. But if they have not optimized comorbid conditions, then it's not okay. If it's suspected sleep apnea, if they have optimized comorbid conditions, minimal opioid, again, it is okay to go ahead. So there are medical legal cases of sleep apnea. And this is just one recent example, which is published recently. There were 54 medical legal cases. And both ENT surgeons and anesthesiologists is involved in most of the medical lawsuit. Half of them are deaf, and a lot of it is permanent neurological deficit and brain damage. The intra-op complications, inappropriate medication, inadequate monitoring account for the rest of them. So what should we do for outpatient surgery? Communication, 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 just like real estate location, location, and locations. So inform the surgeons and nurses that the patients suffer from sleep apnea. Inform the patient and their family of the risk. It is very important to avoid opioid if possible. And also ask the patient not to sleep in the bed and use a recliner. If they don't have a recliner, ask them to sit up to sleep. And if they require an opioid, is to cut the pill in half. So how about periop management? Patient control analgesia is patient central apnea, patient cardiac arrest, and please call attorney. The American Society of Anesthesiologists actually published a guideline in 2006, and then they again published one this year. So there are several factors involved about the sleep apnea, whether they're on CPAP, whether the surgery is major or minor, or whether they require opioid or not. This is actually a very interesting study from Bagavi from Mayo Clinic. Essentially, it talks about recurrent PACU event because we cannot monitor every single sleep apnea patients. So they look at respiratory complication and they look at recurrent PACU event. What are the recurrent PACU event? It is oxygen desaturations, apnea, hypopnea, and also if the patient have sedation, analgesic mismatch. That means they have taken some morphine and they become very drowsy, and when they are awake, they said that they have a lot of pain. So this sedation analgesic mismatch is very common in bariatric sleep apnea patients. So essentially, if the patient is low risk of sleep apnea or high risk of sleep apnea by screening, if they don't have any recurrent PACU event, they have very little risk of having complication in the ward. However, if they have recurrent PACU event identified by the nurses, even if they don't have sleep apnea risk, they will, 11% of them will have respiratory complication in the ward. And if they actually identify as high risk and they also have recurrent PACU event, 1/3 of them will suffer from post-op respiratory complications. How about peri-op management? So essentially for suspected sleep apnea, and if they have recurrent PACU event, yes, then they should be monitored. If they don't have recurrent PACU event, they probably can go home or the ward. For the non-sleep apnea patient, they should be monitored extra hour in the PACU event. Again, if they are non-compliant with CPAP, they have moderate or severe sleep apnea, they have recurrent PACU event, yes, monitor bed. And if no, then again, home or ward depends on the procedure. And Vancouver General actually have developed some outline in which they have some orders how to approach this patient, and it is on our Stop Bank website. So it is very important to avoid pre-medication, especially any benzodiazepine like midazolam or Valium. And aspiration prophylaxis is important. Again, looking at the comorbid conditions, and we should instruct the patient to bring the CPAP, and also we should evaluate the airway. Sleep apnea is associated with 22% incidence of difficult intubations. And this is a difficult intubation in a patient that have sleep apnea not treated by CPAP. And you can see that the airway is very edematous. And edematous airway makes it very difficult to intubate. But worse still, it is in the post-op period that they may develop respiratory complication. However, if the patient is on CPAP, the edema will decrease and will make it so much better. So the optimal position of these patients are the reverse transdermal positions, which is 30% head up. And also we should use the head positions with the true pillow to help us to identify. And this morning, probably some of them have been discussed. And this is a most recent study which is published about 40,000 sleep apnea patients undergoing hip and knee surgery. And they actually find the risk for post-op complication is lower in the regional anesthesia group. So in that group of regional anesthesia, there is decreased need for mechanical ventilation, length of stay, and cost. How about sleep apnea and opioids? The morphine actually causes central respiratory depression. Second, it will cause sedation. Third, it will cause upper airway obstruction by itself. Why? The reason is the genioglossus muscle, which is the primary airway dilator, and this muscle is suppressed by propofol and opioid. And it has been shown in children by Karen Brown in Montreal that those patients who have tonsillectomy and sleep apnea, they require 50% less fentanyl. And also, Anthony Duffus from Stanford also shows that in adults, the hypoxia from the sleep apnea is associated with enhanced sensitivity to the analgesic dose of opioid. He also did studies in volunteer looking at the opioid, and it does shows that less opioid is better for the sleep apnea patients. And ketamine has been shown in animals that is a respiratory stimulant, so it may be a good drug to use in sleep apnea patients. And neostigmine also can cause problem. This is a new drug. It's not available, it's in stage 2, and anesthesiology, there is an article just published recently and say that this drug actually may reverse opioid-induced respiratory depressions. So for the post-op management of sleep apnea patient, it's very important to have a sitting or lateral positions. The Anesthesia Patient Safety Foundation actually do recommend that these patients should be monitored. So I would like to emphasize to you, if you have a patient, a bariatric patient that get into trouble in the post-op period, often they have to go to ICU or step-down unit, look at the bicarbonate. Why? Every increase in apnea-hypopnea index would increase the bicarbonate by 0.17 millimeter mole per liter. So a lot of the patients that have obesity hypoventilation syndrome have bicarbonate very high, like in the 30, 31, 32, 33. So for the patients that have obesity hypoventilation syndrome, it is essential to rule out that they are low risk for obesity hypoventilation syndrome or if they are high risk. Because if they are high risk, it's very important to identify them and treat them before surgery. Next, I would use the last couple of minutes to talk about the CPAP treatment. So how about CPAP? The Bucinic CPAP is actually very useful. It's a very small little device that actually invented by Dr. Bucinic, who is a French anesthesiologist. Very high level flow, about 10 or 15 liters will go through a very narrow channel and create a turbulence to create actually a PEP therapy for these patients. However, a lot of the patients who have sleep apnea, they actually may not receive the CPAP when they're in hospital because we are not ordering it. And also, patients that have CPAP, a lot of the patients, even they refer, they are non-compliant with their CPAP. And there are patients that are on CPAP, actually, they will still desaturate. So I'm going to finish in 1 or 2 minutes. The auto CPAP study is a study that we did. We find that actually with that, the patient which is in red, these are the control patients. And those in green are the CPAP patients. And those who are in green, there is less sleep apnea, less oxygen desaturations. So in conclusion, the STOP questionnaire, patient may be at risk whether they are thick, big, or small. Use the stop bang and regional anesthesia, general anesthesia, you may have to intubate and monitor these patients. Don't use opioid, use stop bang, use true pillows, use recruitment maneuver, use short-acting drugs. So thank you very much for your attention.
Bueno, como habíamos dicho, excelente exposición, una vez más, no es ninguna sorpresa. Como veníamos diciendo anteriormente, fíjense que continuamos girando todo alrededor de los problemas que podemos tener con el intercambio ventilatorio, con el intercambio gaseoso en estos pacientes. Y siempre tratando de tener precaución con la posición, con el potencial, la potencial dificultad que podemos tener en el manejo de la vía aérea, no solo para instrumentarla, sino también para ventilarlos con máscara. El problema de, uno muchas veces dice, es un paciente que seguramente va a ser difícil de ventilar, va a ser difícil de intubar, pero pocas veces uno piensa va a ser difícil de proveerle analgesia. Ya lo vamos a ver. En la próxima charla, otra amiga más, por suerte, en este caso la doctora Anu Guaida. Anu no está físicamente acá, pero va a estar a través de internet. Y nos va a hablar de la relación que existe entre la respiración, el dolor y los problemas que ha estado comentando Frances Chung. Anu es profesora adjunta del Departamento de Anestesiología de la Universidad de Louisville. Actualmente es secretaria de la Sociedad Internacional de Manejo Preoperatorio del Paciente Obeso Mórbido. Es muy activa en este aspecto, es muy activa en el aspecto educacional y de hecho he tenido el placer de escribir un capítulo de un libro juntos con Anu que posteriormente vamos a comentar. Anu, hi.
Yep. Hi, Adrian. Thank you, Adrian and Mario and Santiago, everyone. Oh. Okay, I'll go
Mario,
when, yes.
Okay, okay. Let's wait, okay. Esperamos un poquito que se ajuste el sonido. Así Anu puede comenzar. Mientras tanto,
Hello?
vayan pensando las preguntas que van a hacer después.
Hi, Adrian. Can you hear me?
Aquellos que no hayan the microphone. She's got the mic muted. No.
No.
Mario,
Oh.
¿puede? Que tiene muteado el
Hello? Hello?
No.
Yes, can you hear?
Are you reaching?
I'm talking. I think you can't hear me for some reason.
Es como una película de suspenso.
Mario, hi Adrian.
Mario, maybe lo que podríamos hacer es que cambiemos el orden de las charlas y probamos. ¿Cambiamos el orden? ¿Sí? Jan, would you agree to change the order of the lectures so you can start, we can solve this technical problem and that would be fine. So, entonces la idea es que cambiamos un poquito el orden de las charlas. El doctor Jan Moulier ya fue presentado anteriormente, es jefe de anestesia del Hospital Saint John en Brujas, Bélgica, presidente de la Sociedad Europea de Manejo Preoperatorio del Paciente Obeso Mórbido.
Hello.
Y Jan precisamente va a hablar de una de las cosas interesantes que muchos de ustedes se habrán estado preguntando, de hecho ya me han preguntado afuera, si yo no le puedo dar opioides, ¿qué hago? Jan.
Hello, hello.
It's a pleasure for me here just to start again, and what I will talk about is about using no opioids for general anesthesia. And it's a pleasure too that we all know that to achieve this, the best way is to use local region anesthesia. However, this is not always possible. And Adrian, my good friend, he will show in the next lecture, or if Anu get connected thereafter, will no problem. He will show the value of using local regional anesthesia. Nevertheless, if it's not possible to use local regional anesthesia, we have today another option, an option of using no opioids during general anesthesia. And this is a little bit what I will talk about. We all have heard many reasons already to avoid the opioids post-operative and even perioperative. But is it possible to work and to do general anesthesia without opioids? Well, that's what it's all about, and that's what I will talk about. And so, no opioids during surgery.
Hello.
Do we have other solutions? Well, general anesthesia consists of several components, and the patient should be unconscious if it's not local regional. There should be immobility, and that's the brainstem, the spinal cord. That is not always essential, so sometimes we don't need this. But very important is the control of the autonomic reflexes, the vagal and sympathetic system. This is crucial. And there's also reversibility of all of the above. Amnesia, is that needed? Well, that is irrelevant if you're unconscious already. And then the sixth part, analgesia. Do we need analgesia when a patient is unconscious? Again, actually, there is no pain. Pain is a psychological effect when you are awake. However, nociceptive stimuli can still have an impact on your sympathetic system. So there's no analgesia needed, but there's a block of the autonomic system required. Suppression of hormonal stress response is also important. Control of immunological responses too, because most of the time we are blocking this too much. And the last thing, maybe that's not for today, but in the future we will talk also a lot on suppression of the inflammatory responses. You can say, oh, this is only the surgeon, this goes. No, also anesthesia and other procedures cause inflammation. And this will again, after the operation, more painful. So again, we need to tackle these problems. Components required after general anesthesia. So when the anesthesia is finished, then it's all different. Then the patient should be on the contrary, full conscious, have full mobility, and then it is important to have analgesia, no pain. So that's and the difference. The green, that are the aspects that remain, the control of neurotic reflexes remain important. And most of the time, this is very hard to achieve. After general, it's easy after local regional, what Adrian will show. That's easy, but after general is difficult. Well, amnesia then, well, sometimes yes, sometimes no. That is required to avoid the unpleasant aspects of being in the hospital and in the operating room afterwards. So the analgesia is essential. And these three others remain: the suppression of the stress response, the inflammatory response, and so on. Why were opioids so successful over the years? Well, opioids block the ascending nociceptive stimuli, and they actually allow to reduce the concentration of the hypnotics. So we were doing anesthesia, a balanced anesthesia, hypnotics with opioids. We were using the opioids not for analgesia, but for blocking the sympathetic system, and at the same time to reduce the hypnotics. We even went a step further. Remember when we were doing cardiac anesthesia without any hypnotic in the time? So we were doing actually opioids, and then we said, no, this is not, we have to add a little bit of hypnotics. So opioids were used not really, not as analgesic, to block sympathetic system and to reduce the hypnotics, because the hypnotics we are thinking about have a negative impact on the cardiovascular system. At the time of the barbiturates, at the time of the halothane, there has a lot of negative impact. Why should we avoid the opioids? Oh, there's so many reasons, so many side effects, we all know, but we sometimes forget about the depression in the respiratory system, obstructive breathing, we have been hearing about this already, pruritus, nausea, vomiting, ileus, constipation, urinary retention, muscle stiffness, addiction. We all thought that is only after several days, but it's very fast. Impaired peripheral perfusion, sleep impact on the REM sleep, we all hear about. All these effects are attributable to the opioids. And just depicting here, one of the inventors of all the synthetic opioids in the world. In Belgium, we had Paul Janssens, and he invented almost all the synthetic opioids you're still using today. And that's maybe also the reason I'm coming from Belgium, where we started also the anesthesia, general anesthesia without opioids. The hyperalgesia to opioids is a problem. And if you look here, just shortly, to the patients who get remifentanil postoperative, you see that these patients will require a lot earlier an additional doses of morphine postoperative compared to the patients who didn't get the short-acting remifentanil during surgery. And another study, it's not randomized, but it's just an observational that the independent predictive factors of severe postoperative pain were just those patients who are getting high doses of sufentanil. Now, you can say this is not real randomized, but this is a nice study here in rats that is explaining a little bit what is happening. These are rats who get a dose of fentanyl or saline, and we look to the pain level required to get a reaction. You will see that during the fentanyl dose, the pain level is rising, as you should just expect. But thereafter, for several days, the pain level is a lot less. That means that having given a dose of fentanyl required for anesthesia lowers your pain level for several days. And wonderful, after 12 days, if you then give a very low dose of fentanyl, like comparable to a dose for analgesia postoperative, again, those rats who had 12 days before fentanyl, again the pain level is dropping compared to those who didn't get any fentanyl before. If at the same time there's inflammation, everything is getting even worse. That means a high dose of fentanyl combined with inflammation accelerates this hyperalgesia for a longer time and to a stronger extent. The only thing is, and we heard about the value of using ketamine. Ketamine actually can reduce the amount of opioids we need. Well, look here, what ketamine is doing. If we add ketamine to these rats, we see that the hyperalgesia postoperative is less, it's still there, and it's shorter. After a few days already, it returns to normal. Stress on itself normally is analgesic, not in rats who get fentanyl dose for anesthesia, except there was ketamine given. Again, there's some reaction, analgesic reaction on stress. So if you use opioids, well, it seems to be good to use an MDA blocker like ketamine to reduce the need for opioids postoperative. Now, these are things you have seen already also. The trouble, if you give patients morphine, you have two troubles. There's the obstructive breathing and the depression of the respiration, both attributable to actually the opioids, like this patient who got opioids and was breathing obstructive after surgery. Morphine itself stimulates inflammation. Inflammation blocks the activity of high-dose morphine on the same time. Anti-inflammatory agents also improve the activity of morphine. And if you've heard about new drugs coming out, so if we can block the inflammation, maybe we need less opioids to be effective. So like here shown, anti-inflammatory agents also by mouses that have genetic zero inflammation, they don't have hyperalgesia, and the analgesic property of morphine remains active. Why should we go opioid-free maybe in every patient, or what are the patients that are available? Well, reduction of known side effects, certainly if your patient has obstructive sleep apnea syndrome, patient has asthma, COPD, respiratory insufficiency, these are all reasons why we should allow or not use opioids at all. Strange enough, a special group are the patients who are addicted to morphine and heroin. It's even very difficult to know what dose you need to give. Or you're giving a dose not enough and your patient will wake up crying of pain, or you give a dose high, really too high, and we have troubles again. And nice thing is, if you work opioid free, you don't need to give higher doses. You may have to give a low dose of your morphine just because of the addiction, but you never need to give these, well, doses, you don't know how much exactly. Prevention of the hyperalgesia postoperative, the acute, but also the chronic problem after 3 months. There is less immunosuppression, but this is still a question if it's really that valuable for oncologic surgery to avoid the opioids there. Very important is they have less sympathetic stress postoperative. And that's one of the things is we are very good with our opioids in a high dose to suppress that, but we cannot maintain that after surgery because the patient should start breathing. And then again, we might have some sympathetic stress. The reason why we have troubles probably with these patients with local regional anesthesia, you can maintain this deep sympathetic block of the system. And the inflammation aspect. Many drugs, and then I come to some of the solution, many drugs affect the sympathetic system and reduces the opioids. And there are many studies shown already, dexmedetomidine, also clonidine, that are even longer available, reduces the amount of morphine and improve your VAS course postoperative. Ketamine, the same aspect, is reducing the amount of opioids you need. Magnesium sulfate, working central, and also reducing the venous tension, again reduces your analgesic needs postoperative. Lidocaine is a great drug to reduce the sympathetic stress at the intubation. It seems to even be better than fentanyl, sufentanil. Well, remifentanil is that short that it is still blocking that very well. Even dexamethasone, but it's blocking more the insult, is again reducing the amount of analgesics required postoperative. So these data are out there, they are well known, and each time you can reduce your opioids. But what Mardecock in Belgium started as the first one was actually combining all these drugs together without any opioids at all anymore. And so then you are able to do a general anesthesia with a multimodal combination of drugs that block the sympathetic system and that have analgesic properties and no opioids needed anymore. But also in the States they recognize that, but this is then a study from the Mayo Clinic where they had also morbidly obese patients with sleep apnea syndrome on dexmedetomidine alone. This was not a real multimodal approach, and so post-operative they still needed morphine in a pump post-operative because it was not really multimodal. Is opioid-free possible? Well, it's possible because patients do not need the anesthetic during his sleep, but need sympathetic block. And for that, essential are the central working drugs like clonidine or dexmedetomidine. And the high-dose hypnotics are not needed anymore to get there. So that was the past, when sometimes you had a choice, or increasing opioids, or increasing hypnotics, with also the troubles you could have with these drugs. Is then there a difference? Well, finally not. Opioids and the non-opioids block the sympathetic system, both will lead to some bradycardia, hypertension, although the speed and the effect are different. So the pharmacology, you still have to learn a lot because there is a speed difference. I'll just show you that where remifentanil is the fast in its action. That's true. Fast and sufentanil and fentanyl. Dexmedetomidine is very slow, and that's one of the big problems. If you want to use it, you have to give it early enough. Before, 5 minutes even before you start your anesthesia. The duration is opposite to the speed of the induction. The drop is dependent on dose and the drug indeed. There might be some problems, like you can have also with your opioids, that if it's not sufficient, remifenil can be easily given as an extra dose. This is more problematic, and at that time, then maybe you need to give some other drugs to treat hypertension, tachycardia, because you will be too late if you rely then on clonidine or dexmedetomidine. Rebound hypertension is also a problem, but it's more for the long-term treatment with the alpha agonist. So the classical triad, where we say we need hypnosis, analgesia, and relaxation if needed, while to achieve unconsciousness, hemodynamic stability, immobilization, we would change that to we need hypnosis, sympathetic block, and relaxation to achieve the same aspects. So the indications have been discussing already. Some contraindications for opioid-free anesthesia being allergic, extreme bradycardia. Relative contraindications are like acute ischemic coronary problems, because the opioids have the impact of actually reducing cardiac output, giving us a little bit of vasoconstriction, and in this way actually reducing the oxygen consumption in the heart. The alpha agonist sympathetic blockade is a little bit the opposite. They are reducing the peripheral resistance, improving the perfusion, but increasing the cardiac output, so the oxygen demand may rise. So if you have main stem coronary artery disease, I would say still not do that. For other elective coronary bypass cases, you can work, and I've been doing that totally opioid-free. Controlled hypotension, that's also difficult to work opioid-free there, because we want actually a very bad perfusion for the surgeon to have a dry field. Sympathetic dysfunction syndromes with orthostatic hypotension, well, you can work opioid-free, but you have to reduce your doses enormously. Otherwise, your patient will be really hypotensive or sleeping too long. The same is true for patients that are very old or on beta blocker. You can do that too, but again, you have to use very, very low doses. This is the Q40 questionnaire that we use to evaluate patients, and one of the things we have been looking to is to the quality of anesthesia, and what follows up is the patients in red getting the opioids, in blue getting the opioid free. There are differences actually, and one of the aspects is the quality of sleep, who seems to be improved by patients who are not getting opioids at all, telling me that the first night sleep seems to be more normal. Probably we have not that REM sleep suppression. That's something we have to now to investigate, if that would be the reason. But we all know, and that was shown already, how opioids have an impact on this morphine sleep. Postoperative pain management after opioid-free, well, you first work out with primary analgesics. And here, lidocaine in a low dose, ketamine in a very low dose, can be continued. And the fact that you didn't use opioids during anesthesia, the patient needs less analgesics to have the same effect. Remember the mouse, where we don't see the hyperalgesia and the drop in the pain sensitivity. So that's the advantage. And suddenly paracetamol and classical NSAIDs are sufficient for many cases to have a patient totally pain-free. Alpha blockers at a very low dose below sedation are still analgesic and can still be given further on. And opioids only are to be used as an escape in a very low dose, in case the rest is not sufficient. And there's nothing dramatically wrong in the case there to use some opioids in a very low dose. If it is someone like with OSAS, where I really want not to give any at all, then we will continue with a very low dose of alpha agonists, alpha blockers, alpha agonists, and lidocaine in this way to prolong the use of our non-opioid analgesics. So yes, it is possible. If you use multimodal analgesia, and by adding, if you can, local region or local anesthesia, it makes it always a lot better actually. So I would say here the opioid paradox is that the less opioids you use during anesthesia, the less opioids you need post-operative. That's another opioid paradox than the one of intensive care. even also on ambulatory care. So for the OFA, this is a scheme you all can find on my website, where these are written out actually, and these are the doses for the induction of dexmedetomidine. It's not up to 1 microgram because you have to load up slower, otherwise you get in hypertension. Lidocaine 1.5 milligram per kilogram, and propofol, magnesium sulfate, the loading dose. A very low dose of ketamine is given over 12 hours. You don't need to give it really at the induction. And we start with the anti-inflammatory agents even before surgery with like dexamethasone, and having a beta blocker calcium agonist ready available, like also ephedrine, in case you should need it. The maintenance of the opioid-free anesthesia, again, it's with clonidine or dexmedetomidine. Here, 0.5 up to 1, depending on the length of the case, per kilogram per hour. The local anesthetic, we will continue with lidocaine. I prefer even to use procaine. It's even shorter working because you might load up with lidocaine too much and your patient per hours being too much sedated, and again, that's a problem. Now, the safety doses are very, very high, and even higher than the 6 milligrams per kilogram per hour, as what is officially written down. The only problem is if you go that high, is that your patient will be sleeping very long. Inhalation anesthesia, for me, is simpler and easier in the morbidly obese patient than is the intravenously. You can work with intravenously with propofol. However, most of the time we have learned to use remifentanil to reduce your propofol infusion. So if you want to go for a TIVA with opioid-free anesthesia, you will need a lot more of propofol to achieve the same dose and hypnotic effect. NMDA blocker, well, that's something important to start before you would ever give some opioids afterwards, and magnesium sulfate, we continue like also paracetamol. The postoperative pain is already used, the non-steroidal opioids, non-opioids. And well, if you really want to continue without any opioid at all, then you should continue with lidocaine, magnesium, and dexmedetomidine. However, now in a very, very low dose below sedation levels. Use opioids, again, correct, only as a last choice and as an analgesic, not as an anesthetic. But this is a real change in our mind, but there is hope we can achieve that. And thanks to this group of patients, like the obstructive sleep apnea syndrome, like the patient with respiratory troubles, that we are really forced to switch earlier and to move in that direction. Thank you. Yeah. And as we have set the tone now, it's my pleasure to introduce here the most important person of this session here, Adrian Alvarez, my good friend. He actually, although we heard America is the place where the obesity really started, it's Adrian who had the vision so many years ago about the importance as an anesthesiologist to deal with obesity. And he was too early in these days, and so that means that together with Jay Brodsky, he was staying that quite long alone in his emphasis on working and putting attention on this issue. Now, after so many years, you see the rooms are overcrowded when we talk about obesity and anesthesia, and so Adrian was right so many years ago that this is something important, it has an impact on the outcome, and we should deal with obesity as an anesthesiologist. And that's what he will now talk. It's about another way, the local regional technique to avoid the opioids. Adrian.
Ahora me van a cargar mi presentación. Ah, no. Marito, decirle que cambiamos el orden por la lógica de la... Bueno, primero...
Hello?
A la sala. Sí.
Hello? So it seems it's working now.
aprovechamos para empezar a interactuar un poquito más. Esto sería lindo que termine como una charla entre todos, donde todos preguntemos. Muchas de las respuestas que hoy trae Francis, que trae Jan, Ashish, Jay, fueron preguntas que nos hicimos encontrando en el Congreso. Decimos, ¿cómo hacemos para poder mantener la analgesia cuando nosotros terminamos de utilizar el remifentanilo, por ejemplo? ¿Eso es mío? Ok. Entonces el tema mío es un abordaje diferente de cómo poder utilizar anestesia regional y analgesia regional para poder dar una analgesia libre de opioides. Muchas veces uno se pregunta, genial, todo lo que dijo Jan está bárbaro, pero muchas veces es complejo poder reproducirlo en todos los lugares. Una anestesia epidural se puede hacer en cualquier lado. Probablemente lo que uno tenga que hacer es aprender a hacerla en un terreno difícil. Pero también yo a veces me pregunto, cuando nosotros hablamos de manejo dificultoso de la vía aérea, no decimos, bueno, este paciente tiene una vía aérea dificultosa, yo no lo intubo, yo me voy y me encargo de otra cosa. No, se desarrollan cosas para poder intubarlo. Y lo mismo debería hacerse con la anestesia regional. Hemos visto recomendaciones de Francis, de la Sociedad de Apnea del Sueño, de Yang, de todos los que estuvimos hablando acá, que la anestesia regional debería tener un lugar. Bueno, yo voy a tratar de hacer que esto sea más o menos entendible. En primer lugar, ¿cuál es el objetivo analgésico que tenemos nosotros cuando nos enfrentamos en cualquier paciente? Incluso en un paciente obeso mórbido. Proveer un soberbio nivel de analgesia dinámica. A mí no me gusta ver un paciente que no le duela, pero que no se mueva. A mí me gusta ver un paciente que no le duela, pero que se siente, que camine, que esté como si antes de comenzar la operación. Que sea capaz de tener una tos eficiente, pueda respirar profundamente, tenga una rápida y activa movilización. Otro de los problemas que tienen estos pacientes es el desarrollo de trombosis venosa profunda y embolismo pulmonar, que sigue siendo la principal causa de muerte. Quiero que se recupere totalmente la conciencia, porque solamente un paciente consciente y sin dolor va a poder colaborar con su rehabilitación. No quiero que tenga náuseas ni vómitos, pero fundamentalmente, en este escenario, no quiero que tenga depresión respiratoria. Manejar la analgesia en un paciente obeso mórbido es un equilibrio extremadamente delicado, porque si yo no controlo bien el dolor, voy a tener alteraciones en la capacidad residual funcional, que va a estar disminuida, voy a tener desarrollo de atelectasias, que vimos que es un problema enorme en estos pacientes, una gran incidencia de fallo respiratorio agudo. Una de las poblaciones que más incidencia de fallo respiratorio agudo tiene en el posoperatorio inmediato es el obeso mórbido, y va a tener retrasada la deambulación, cosa que yo tampoco quiero. Pero por el otro lado, yo le doy morfina, que es el gold estándar para el tratamiento de la analgesia posoperatoria en todo el mundo, y tengo todos los problemas que mencionó Ian, que mencionó Francis. ¿Cuál es el problema con el cual uno se va encontrando a lo largo del tiempo? Al principio, 15 años atrás, un poquito más, nos encontrábamos los primeros intrépidos del mundo, donde se acercaba un cirujano bariátrico y nos decía, Tato, ¿te animás a dormir un paciente gordito? Y yo decía, no sabía de lo que me estaban hablando. Hasta que me mostró una foto, empecé a averiguar lo que era cirugía bariátrica, empecé a buscar publicaciones y no encontré absolutamente nada. Si uno busca la literatura de hace 15, 16 años, no había absolutamente nada. Entonces uno empieza a pensar, bueno, ¿qué hago? Afortunadamente un montón de cosas se hicieron y hoy en día la anestesia para cirugía bariátrica es una cosa segura, que se hace en todo el mundo y que los resultados son buenos. Ahora, eso trajo como consecuencia que los cirujanos dijeron, bueno, si yo puedo operar a este paciente para hacer una cirugía bariátrica por la laparoscopía, también podría operar a ese otro paciente que es obeso mórbido y tiene un cáncer de riñón y le tengo que hacer una nefrectomía. O tengo que hacerle un cuádruple bypass aorto coronario. Antes esos pacientes directamente no se operaban por el riesgo. Hoy en día sí se operan. Y como dijo Jay en su presentación, los pacientes obesos mórbidos tienen más incidencia de determinado tipo de cáncer, más incidencia de muchas enfermedades que tienen resolución quirúrgica y que cualquier anestesiólogo va a tener que enfrentar. Entonces, la cirugía mayor no bariátrica tiene un crecimiento continuo también y la mayoría de las veces se hace por abordaje convencional. Por ejemplo, una toracotomía universal para hacer una neumonectomía. Imagínense que es un caso interesante. Es importante tener en cuenta la relación entre qué tipo de cirugía mayor, cuánto impacto va a tener desde el punto de vista fisiológico, cuál va a ser el abordaje y el tipo de plan analgésico que yo puedo tener en mente para ofrecerle a ese paciente. Lógicamente, de acuerdo totalmente con todo lo que dijo Jan, tenemos que utilizar un esquema de analgesia multimodal intravenosa libre de opioides como primer approach. Para cirugía laparoscópica, usualmente puede ser suficiente. Si ustedes me preguntan a mí, los que me conocen saben que soy un fanático de la anestesia regional y aún en cirugía laparoscópica yo uso anestesia epidural. Yo evalúo mucho también una cosa que en muchos trabajos actualmente no se estudia, pero que hay un gran interés, que es la satisfacción del paciente. Y la satisfacción del paciente es distinta. Si la cirugía es abierta, creo que todos estamos de acuerdo que es insuficiente. Si yo tengo que hacer una hepatectomía y le tengo que hacer una incisión en boca de horno a un paciente, creo que cualquiera diría, yo le pongo una anestesia epidural torácica. Lo mismo si tengo que hacer una toracotomía universal. Entonces, probablemente la anestesia regional tiene un lugar. Vamos a empezar a pensar juntos a través de toda una serie de preguntas, que son las preguntas que yo me fui haciendo a lo largo del tiempo para encontrar una estrategia que a mí me convenza. Desde el punto de vista fisiopatológico, ¿cuál es el aparato más afectado en el obeso mórbido, en gravedad y en precocidad? El aparato respiratorio. O sea, yo cuando pienso en analgesia y cuando pienso en cualquier estrategia de tratamiento anestésico que voy a estar haciendo en un paciente obeso mórbido, tengo que pensar en el efecto, en el impacto que va a tener en la función ventilatoria. Segundo lugar, desde el punto de vista farmacológico, ¿cuál es el riesgo que tengo de usar opioides en pacientes que tienen apnea de sueño? Prácticamente todos los pacientes obesos mórbidos que operamos para cirugía bariátrica tienen apnea del sueño. Y vimos que los opioides, Francis, no son una buena idea. Desde el punto de vista anestesiológico, en cualquier población, ¿cuál es la técnica que brinda la mejor calidad de analgesia con la menor cantidad de opioides? Cualquiera. Cuando uno dice, tengo que hacer un viejito, una cadera, es tarde, yo le hago un bloqueíto con poquitito y ni loco le pongo ni una gama de fentanilo, ¿no es cierto? Bueno, porque es lo que nos permite dar una excelente analgesia sin utilizar opioides. Supongamos que tenemos ahora un caso, un paciente que se va a operar de un túnel carpiano bilateral que tiene probablemente un manejo dificultoso de la vía aérea por la evaluación preanestésica. No es un paciente obeso mórbido, es un paciente con un potencial manejo dificultoso de la vía aérea. Para la ventilación o para la intubación, ¿no sería razonable optar por la anestesia regional? ¿Ustedes no le harían una anestesia regional, una plexual? Yo creo que sería lo ideal. Tendría todos los dispositivos de manejo de vía aérea dificultosa a mano, pero optaría por hacer una anestesia regional. Supongamos que tenemos que hacer un reemplazo de cadera en un paciente que es un viejito en regular estado general, todos nosotros, creo que en todo el mundo nos enfrentamos con esto, es un paciente tabaquista severo, es EPOC, tiene un corazón pulmonar crónico, o sea que tiene una escasa reserva cardiorrespiratoria, símil obeso mórbido. El obeso mórbido tiene una escasa reserva cardiorrespiratoria. ¿No sería razonable hacerle una anestesia regional? Yo creo que todos, si salen de acá y se van a la sesión de anestesia regional, cuando hablen de cadera le van a decir, háganle un bloqueo. Si yo tengo que hacer una lobectomía por una toracotomía universal, ¿vieron lo que es esa incisión, más los retractores, más el cirujano trabajando adentro? Un paciente que tiene un cáncer de pulmón, es delgado, no es un obeso mórbido, pero tiene apnea de sueño, Jay es delgado y sufre de apnea de sueño, y tiene mala reserva respiratoria. ¿No sería razonable para la analgesia posoperatoria hacerle una epidural torácica? Yo creo que, salvo que esté absolutamente contraindicada, todos le haríamos una epidural torácica. Ahora, el obeso mórbido tiene todas estas circunstancias que hemos mencionado anteriormente juntas en una sola persona. Tiene un manejo dificultoso de la vía aérea, seguramente para la ventilación con máscara y posiblemente para la instrumentación de la tráquea. tiene escasa reserva cardiorrespiratoria, casi seguro tiene una disfunción diastólica y casi seguro tiene caída de los volúmenes y capacidades pulmonares, y es muy probable que tenga apnea de sueño entre moderada o severa. ¿No sería entonces razonable usar una estrategia regional? Yo creo que sí. Francis lo mencionó. Enfrentados a este problema, el mundo entero, mayor cantidad de pacientes de obesos mórbidos, mayor cantidad de cirugía bariátrica, se empiezan a ver problemas, empieza a haber muerte, empieza a haber juicios, empieza a ver, bueno, ¿dónde está el problema? Se comenzaron a hacer consensos, se escribieron recomendaciones. Dentro de las recomendaciones, ustedes fíjense, uso de técnicas regionales siempre que sea posible. Pacientes con apnea de sueño, no están hablando de pacientes obesos mórbidos con apnea de sueño, o sea, cualquier paciente con apnea de sueño debería optarse por anestesia regional. Excluir opioides de la anestesia regional si es que se utiliza y tratar de usar un esquema multimodal, o sea, utilizar AINES, utilizar otro tipo de drogas que nos permita reducir el requerimiento de opioides. Estas son recomendaciones de la Sociedad Americana de Anestesiología, que es prácticamente la Biblia de todos los anestesiólogos del mundo. De hecho, como les comenté, hace 15 años no había nada escrito, afortunadamente después de a poquito nos fuimos juntando. Creo que en el 2004 publicamos la primera edición del primer libro de manejo perioperatorio de la obesidad mórbida. Michel Struys, que está por acá, escribió el capítulo de farmacocinética y farmacodinamia en el paciente obeso mórbido. Y Jay Brodsky y Pedro Tanaka, los dos de la Universidad de Stanford, pusieron toda esta serie de ventajas potenciales de la anestesia regional en el capítulo de anestesia regional de obesidad mórbida. Manejo mínimo de la vía aérea, menor depresión cardiorrespiratoria, mejor analgesia posoperatoria, mayor satisfacción del paciente, reducción del uso de opioides, menor incidencia de náuseas y vómitos posoperatorios y recuperación más rápida. ¿Es lo que todos queremos o no es lo que todos queremos? Pero también escribieron cuáles son las desventajas potenciales, dónde está el problema. Posicionamiento difícil, técnica difícil, necesidad de agujas especiales y mayor chance de bloqueo inadecuado. Entonces, cuando yo me encuentro con una situación así, digo, bueno, ¿de qué manera yo puedo mejorar la técnica? Porque si no sería, este paciente difícil de intubar, yo me voy y que se arregle. No, este paciente difícil de bloquear, tengo que aprender a hacer un bloqueo si es que el bloqueo es la mejor opción que tengo. Entonces, esta sería la respuesta de por qué se usa poco. Uno cuando dice, bueno, le tendría que hacer una epidural torácica, habitualmente se queda así. Cuando el paciente le dice, bueno, yo no quiero que me duela y no me quiero morir. Y yo al principio tenía esa cara, decía, ¿cómo hago? ¿Cómo hago para conseguir hacer una epidural torácica en este paciente? La anestesia regional depende en gran medida de un adecuado reconocimiento anatómico. Y el problema muchas veces está en reconocer las estructuras que habitualmente nosotros reconocemos para hacer un bloqueo, por ejemplo, neuraxial. Las apófisis espinosas, etcétera, punta de la escápula. Ahora, yo me hago otra pregunta. Los anestesiólogos en general, no hablemos de obesidad mórbida. ¿Realmente sabemos hacer anestesia regional? ¿Todos sabemos hacer anestesia regional como deberíamos? Este gráfico es bastante ilustrativo. Acá hay un anestesiólogo que lo está atravesando con la aguja y le está haciendo la punta de la aguja por la pared anterior del abdomen. Yo puse esa cara, la cara de Smigel, cuando encontré esta publicación, que fíjense es del año 2012. Hicieron una investigación a ver cuál era la tasa de fracaso en la población general de la anestesia epidural lumbar, 27%, y de la anestesia epidural torácica, 32%. Esto significa que cada 10 pacientes que un anestesiólogo norteamericano le va a hacer una anestesia epidural torácica, siendo delgado, falla. Sin embargo, cuando nosotros leemos los artículos comparativos de anestesia regional versus general, el grupo que pertenece al regional se considera que el hecho de haber agarrado una aguja epidural eso es intention to treat. O sea, ese paciente se cuenta como que se le hizo la epidural. Yo les pregunto, si yo voy a usar morfina endovenosa, ¿puede haber 3 personas que le erren al agujerito donde tienen que inyectar la morfina? Imposible. O sea que son comparaciones muchas veces, si uno no lee adecuadamente el trabajo, inciertas. Entonces, voy a continuar con la cara de Miguel hasta que esto se revierta. ¿Qué se debería hacer? En primer lugar, tratar de reconocer la anatomía. Si el problema, la clave para poder hacer un bloqueo bien es reconocer la anatomía, lo primero que tengo que hacer es tratar de reconocer la anatomía. Y hay muchas publicaciones que ya muestran en pacientes delgados, cualquiera que hace anestesia regional, ya el ecógrafo es prácticamente lo mismo que tener una aguja. Uno, si no tiene el ecógrafo, no hace el bloqueo regional. O sea que no tengo la más mínima duda que para el bloqueo neuraxial en el futuro la ecografía va a ser fundamental en estos pacientes. En segundo lugar, es fundamental conocer la técnica, porque si uno se va de acá y dice, bueno, yo hice una epidural en la residencia lumbar en un flaquito, pero dijeron que la epidural torácica es bárbara en los huesos mórbidos, y si se van mañana a hacerlo, seguramente les va a ir mal. Y van a decir, es mentira, lo que dijo el petizo ese en el SHERATON, esto es mentira. Entonces, tenemos que conocer la técnica. Además de conocer la técnica, tenemos que tener una práctica regular, porque esto está asociado a lo que se llama memoria muscular. Ustedes habrán visto la película de Forrest Gump. Forrest Gump un día empieza a jugar al ping-pong, apenas pasa la pelotita de un lado para el otro, pero ¿qué pasó? Jugaba, al día siguiente sigue jugando, al cabo de 2 años fue campeón mundial de ping-pong. Y no era un tipo brillante. No es necesario ser brillante para poder hacer bien una anestesia regional. Solamente hay que conocer la técnica y practicar en forma regular. Y probablemente sea necesario tener un entrenamiento específico para esta población. Nadie duda que para hacer anestesia neonatal alguien tiene que saber trabajar con pacientes neonatos. Para hacer anestesia cardiovascular uno tiene que saber trabajar con pacientes cardiovasculares. Pero a veces dice, y bueno, pero obesidad mórbida, no, bueno, traerlo, tengo que hacer esto, tengo que hacer lo otro. A veces nos enteramos que es obeso mórbido cuando lo tenemos en el quirófano. Con respecto a reconocer la anatomía, todos sabemos que la identificación anatómica por palpación está dificultada en la obesidad. Cuanto más obeso es el paciente, más difícil es reconocer la anatomía. La dificultad en identificar la anatomía es un predictor de riesgo de un acceso epidural dificultoso. Si yo no puedo palpar, es bastante más probable que pueda ser un bloqueo efectivo a que si yo sí puedo palpar. Y el uso de la ultrasonografía, todos sabemos que facilita el reconocimiento anatómico, sobre todo en circunstancias especiales como puede ser un panículo adiposo de 10 centímetros. Entonces, yo creo que en el futuro, el gap que tenemos entre reconocer la anatomía en el Vitruvio o en esta paciente va a ser el puente de la ultrasonografía. La ultrasonografía nos va a permitir reconocer adecuadamente la anatomía. Y ustedes fíjense que el tema de conocer la técnica y tener una práctica regular es verdad desde siempre. El doctor de acá es, creo que después de mi papá, una de las personas que yo más quiero, es Philip Bromage. Philip Bromage es el padre de la anestesia epidural en el mundo entero. En ese momento la Sociedad Americana de Obstetricia le había dado la medalla de oro por todo lo que él había aportado en la analgesia de las pacientes obstétricas. Pero también Philip Bromage trabajaba en este hospital, que es el Royal Victoria Hospital de la Universidad de Montreal, y ahí trabajaba con Mason, y tenían un centro de cirugía bariátrica. Fueron los pioneros de la cirugía bariátrica a nivel mundial. ¿Y ustedes saben qué anestesia le hacía Bromage a Mason? Le hacía epidural torácica. Le hacía anestesia epidural torácica. Y que, claro, obviamente, conocía la técnica y tenía práctica. ¿Qué vio? Que había una extraordinaria reducción del requerimiento de terapia intensiva, del tiempo de ventilación mecánica, una recuperación más rápida, una calidad de analgesia soberbia, una disminución muy significativa del requerimiento de anestésicos generales y fundamentalmente el requerimiento opioide, 1956. Vamos entonces ahora, si realmente alguien necesitaría un entrenamiento especial cuando trata estos pacientes. Hace un par de años, Jay Brodsky y Yigal Leikin es un anestesiólogo de Italia, nos convocó a Francis, a Jan, a Shish, a mí, para escribir este libro muy interesante que es acerca de controversias en el manejo perioperatorio del paciente obeso mórbido. Y tuve la suerte de que me tocara un tema que también me encanta, que es la educación. Y entonces el tema era, los anestesiólogos que van a hacer en forma rutinaria pacientes obesos mórbidos, ¿necesitarían un entrenamiento ideal? Y yo les diría que sí. Si quieren, lean ese capítulo. ¿Qué recomendaciones les puedo dar? En este momento, desafortunadamente, la cantidad de literatura publicada al respecto es muy escaso, pero yo tengo más de 15 años de hacer anestesia en pacientes con obesidad mórbida y más de 10 años utilizando esta técnica de anestesia epidural torácica combinada con anestesia general. Todos los que me conocen de acá en la Argentina me han visto dar vuelta con mis catéteres y mis agujas por todos lados. Yo creo que una de las cosas que me han facilitado mucho la técnica es utilizar este tipo de decúbito, que es un decúbito pronoblicuo. Lo que es importante es que el paciente esté acostado en forma cómoda, dejar la pelvis a 90 grados con respecto a la superficie de la camilla y hacer que rote los hombros, el plano de los hombros, 45 grados. El motivo es múltiple. En primer lugar, es una posición segura. Si yo tengo un paciente de 260 kilos sentado en el borde de esa mesa y yo voy a estar 15, 20 minutos, media hora pinchándole la espalda, no puedo, le bajan la cabeza, lo están por operar, hace 3 días que está en ayunas, es muy probable que ese paciente se desmaya. Y si ese paciente se desmaya, va a caer 2 o 3 pisos más abajo, y juntos vamos a ser nosotros, y atrás va a venir 911, los abogados. Entonces, la posición tiene que ser segura y cómoda. Yo lo que le digo al paciente una vez que está en esa posición es, hacete el desmayado, a ver si se mueve, y ustedes van a ver que el paciente no se mueve. Y de hecho yo lo que hago es, me tiro en el piso y le muestro al paciente cuál es la posición. Si nosotros le tenemos que decir al paciente, quiero que usted adopte un decúbito lateral, con la pelvis a 90 grados con respecto al plano de la camilla, y rote los hombros de manera tal que estén a 45, no va a entender nada. Pero si ustedes hacen así, se ponen en la camilla, se acuestan como si fueran a dormir una siesta, y tiran el hombro para adelante, lo único que tienen que hacer es decirle al paciente, haz lo mismo que hice yo, y se ponen perfectamente en esta posición. Además de ser una posición segura, lo que yo quiero es crear una asimetría de la relación de la lámina superior con respecto a la lámina inferior, de un lado con respecto al otro. La columna torácica tiene una anatomía que permite el movimiento de rotación. Entonces yo de esa manera, si no puedo entrar de un lado, entro del otro. Si un lado se cierra, el otro lado se abre. Es lo mismo que ocurre con una escoliosis. Y lo otro, también absolutamente recomendable, es utilizar la vía paramediana. Ustedes imagínense que cuando uno usa la vía mediana, está yendo con la aguja por un desfiladero óseo que les va a permitir un mínimo o nulo movimiento cefalocaudal a probablemente 13 centímetros de distancia de la piel. Por vía paramediana, ustedes tienen prácticamente 100 grados de versatilidad de movimiento cefalocaudal y 90 grados en sentido transversal. ¿Cuál sería mi recomendación? Comiencen a hacer anestesia epidural lumbar, después torácica en pacientes delgados y después ir creciendo en el BMI a medida que se vayan sintiendo cómodos con la técnica. ¿Cuál es la situación actual? No cabe duda que la analgesia del paciente con obesidad mórbida es una analgesia de alto riesgo. Ustedes piensen, es dificultosa la vía aérea, pero es dificultosa la analgesia, y muchas veces se mueren por la vía aérea, pero por un problema generado por la analgesia. La analgesia regional es una opción razonable, lamentablemente hay publicadas altas tasas de fracaso y se necesitan más estudios. ¿Qué necesitamos? Educación, entrenamiento, práctica regular y más estudios. Nada más, gracias. No, ahora la voy a introducir a Anu. Marito, ¿Anu está? Anu, are you okay?
Yes, I'm here. Can you hear me?
Okay, okay, go ahead.
All right. Adrian, I want to really thank you very much for organizing this whole session, where I'm sitting in United States in Louisville, Kentucky, and talking to you with the help of Mario and Santiago. So everybody has laid a very good background of what I'm going to talk about and really understand the importance of this. So next slide, please. As you know, that obesity and sleep disordered breathing can occur independent of each other. However, many times you will see that they will go hand in hand, and it's like two bad guys meeting because they'll cause all the bad things that you don't want to happen. Both obesity and sleep disordered breathing will reduce the upper airway size, which is very important to us anesthesiologists, as you know, for intubation. It reduces the amount, the way you can ventilate the patient. They both increase upper airway collapsibility because of all that soft tissue that is in the mouth. These patients, obese patients, have reduced lung volumes, especially FRC, or the functional residual capacity. They don't respond very well to increased CO2 levels after they get sedated, and they also have increased respiratory work. And when all this is combined with the metabolic syndrome and systemic inflammation, where they already have some cardiovascular disease, it's not fun to deal with these patients. These patients have a lot of fat in their tongue. Next slide, please. Yeah, thank you. And especially the posterior third of the tongue has the maximum amount of fat, and as morbid obesity increases, the amount of fat in that posterior third of the tongue increases, which leads to increased Mallampati classification. As you can see, this macroglossia, when you ask the patient to open their mouth, if the posterior third of the tongue will cover the observable pharyngeal space where the upper part is above the mandibular occlusal plane, it makes it a Mallampati 4, and as we know, it is very difficult to intubate patient. Also, if you ask your patient to open the mouth, in addition to the large, if they don't have a large tongue but they have a view like this is called lateral narrowing, where 25% of the posterior pharyngeal space is occluded because of that lateral, those lateral peritonsillar tissue. This is also difficult to intubate patient, even if you can see that posterior pharyngeal wall. Now, in a sleep apnea patient, this entire soft tissue mass will be about 30 cubic centimeters more in the OSA patient compared to a non-obese patient, obese with OSA patient. And even if these patients reduce weight and you're taking care of them after they've had bariatric surgery, the tongue volume may not reduce. And in fact, you need a upper airway fat reduction, which is like the posterior part of the tongue and the subhyoid area. You need a reduction of 17 cubic centimeters to be able to get a 31% reduction in the apnea-hypopnea index. And these patients can redevelop sleep apnea if there is an increase in the upper airway tissue by about 20 to 30 cubic centimeters. Now, what's the connection between sleep, respiration, and pain? You've seen a little bit of how opioids actually affect this. You might have seen this morning some slides about how respiration and postoperative complications are severely increased in sleep apnea patients. The PACU part, the recovery room, and the first to third postoperative nights are very dangerous. Part of the problem is because they start with a lower functional residual capacity. So you've probably seen this slide multiple times. As the BMI goes up from the 35 to 60 range, the functional residual capacity reduces from 50 to 80% of predicted. And This reduces our apnea time that's available to us. No, next slide, please. The last slide. Yeah, this reduces the apnea time. So in a normal individual, a 70-kilo individual, we have about 9 to 10 minutes available to us before their saturations will start dropping below 90%. In a sleep apnea patient, we only have 3 to 3.5 minutes. Like this obese patient, you can see the leftmost curve that you can see is a 127-kilo patient. You only have about 3 to 3.5 minutes before the patients will start desaturating to less than 90%. So that's the time you have to obtain a definitive airway in these patients. And now, how does this affect pain? How does all this respiration and sleep and everything affect how we treat pain in these sleep apnea patients? So, next slide, please. Most of the early work came from Canada, again, like like this morning's work that you saw, Dr. Chung's. There was this group of investigators from Canada that looked at young children who were undergoing adenotonsillectomy and looked at the correlation between their post-operative narcotic requirements or opioid requirements, tried to correlate it with the lowest oxygen saturations pre-operatively, and they found that there was a direct correlation between lowest pre-op oxygen saturation to the amount of morphine they needed post-operatively. So the first study that was published in 2004 was a retrospective study, and the second study was a prospective study that was based on the retrospective analysis. So in the first study, their hypothesis was that children who have recurrent hypoxemia, especially severe hypoxemia, they may have altered central opioid functionality. That is, their mu-opioid receptors may respond differently to narcotics than patients who have less hypoxia, and that was a hypothesis which is what they were trying to prove. So they looked at adenotonsillectomy patients who were otherwise healthy. All of these patients were getting some fentanyl for intraoperative pain relief. All of the patients were extubated in the operating room, and all of these patients received morphine as a post-operative analgesic. And you can see from these two curves that as the patient's saturation dropped, on the right-hand side it's the 100% curve, while on the left-hand side 50%. And as the saturation was lower in the preoperative period, their cumulative morphine requirements after surgery were lower. So the severe sleep apneic patients needed much less opioids post-operatively to take care of their pain compared to the ones that did not have such severe desaturations preoperatively. And there were about 4 patients who did not need any morphine at all, so they did not have any pain and did not require any postoperative analgesia. The authors also noted that there was a direct correlation between age and post-op morphine requirements. So the younger the patients, the lower their requirements of post-operative morphine. Based on this analysis, they actually came up with a formula that took into account their oxygen saturation and their age, and they came up with a formula of how we should be administering morphine to these young children undergoing tonsillectomy. So they enrolled 22 children with obstructive sleep apnea. They noted their pre-op oxygen saturations. The patients received post-op morphine every 7 minutes by one of the 2 regimens. Either they got standardized dose of 0.1 milligram per kilo of morphine if needed, or they were given the calculated dose that was based on the combination of saturation and age. And they stratified the data into patients that were less than or equal to 85% saturated or more than 85% saturated, so according to the severity of their desaturation. And This graph actually shows the correlation between saturation and morphine requirements. The colored dots are the one that were given the standard dose, that's 0.1 milligram per kilo, and the open dots are the one that got the calculated dose. And you can see in both the groups, as the saturations were lower, lower were the morphine requirements. There's a direct correlation. And this essentially suggests the change in central sensitivity to opioids, to exogenous opioids, which is directly correlated to the lower oxygen saturations. So these three graphs are, again, the striped one is the calculated and the dark one is the standard. And the patients with less saturation or less than 85% saturation needed less morphine, less number of doses with every injection, and total less number of injections compared to patients who had higher oxygen saturations. Next slide, please. So they actually looked at the same model in the lab, and they took young rats. And one group of rats were just normoxic. You know, they were exposed to normoxia during the entire day. While there was another group of rats that they exposed to 7 hours of hypoxia at night, so which mimicked a sleep apneic patient where they would have multiple episodes of hypoxia at night. So, and then they gave one single dose of fentanyl after 17 days of hypoxia to these patients. They gave 120 mics per kilo dose, which is a ED50 for fentanyl for rats for respiratory depression. And they started measuring their tidal volume, their minute ventilation, their respiratory frequency, and their respiratory drive, which is tidal volume divided by inspiratory time, starting at 8 minutes up to 26 minutes. And their speculation was that the hypoxia, the group that was subjected to hypoxia, would have a repeated release of endogenous opioids, which would change their sensitivity to that exogenous fentanyl. And these are the results. The first minute ventilation, the second is respiratory rate, the third is tidal volume, and the fourth is ventilatory drive. And you can see all of those are reduced in the hypoxic rats compared to the normoxic rats, which proved their hypothesis that when you subject rats to recurrent hypoxia like a sleep apneic patients, they behave differently to exogenous opioids than someone who has not been exposed to hypoxia. And one of the first people who actually pointed this out was Dr. Kellett. He's one of the surgeons from Netherlands we all know about. And he looked at deaths post-operatively. There were a total number of 744 deaths in this particular hospital, of which 18 deaths were totally unexplained. Literally, the charts of these 18 patients said that the patient was just found dead in their bed. So he took those 18 deaths and divided them according to the time of the death. So you can see the first 2 patients were in the 8 a.m. to 4 p.m. group. The next 3 patients were in the 4 p.m. to midnight group, and the other 11 patients were in the death after midnight group. And maximum patients post-operatively died after midnight. So there seems to be a direct correlation between the timing of death and unexpected deaths. The blank bars that you are seeing are the patients where no autopsy was done, but they were determined to be totally unexpected and had no cause, and the others where autopsy was done. And out of the colored ones, there were 5 patients who had determined PE. And the others, there was no cause to be found. And Dr. Kellett suggested that there might be some mechanism post-operatively that might be causing increased risk of cardiac deaths after midnight. And he even suggested sleep disordered breathing or obstructive sleep apnea might be the cause of death happening after midnight in surgical patients, and that we should look at it more closely. A few years ago, New England Journal of Medicine also looked at the day and night pattern or the circadian rhythm of sudden death in obstructive sleep apnea patients versus non-obstructive sleep apnea patients versus just general population. And you can see from this graph that, again, the first 3 bars are deaths happening after midnight. So this is from midnight to 6 a.m. And the uncolored bar is patients with non-obstructive sleep apnea. And 46% of the patients who died after midnight, and these are non-surgical patients, they did not get any narcotics or opioids or anesthetic, but there are more patients that die of cardiac causes at night who have obstructive sleep apnea compared to the general population or patients with no sleep apnea. Patients who die during the daytime, that is between 6 a.m. to noon, most of the patients have no sleep apnea, or they are the general population versus only 20% with the sleep apnea patients. So you can see the trend that it seems that sleep apnea patients seem to die suddenly at night, whether they have surgery or they don't have surgery. Their timing of death is at night. This death is directly correlated to the apnea-hypopnea index. So the first colored square is the general population, and with an apnea-hypopnea index of 5 to 39, there's almost a doubling of the death rate after midnight. And as the apnea-hypopnea index goes above 40, it's a 2.6 times relative risk of patients dying after midnight. Anesthesia Patient Safety Foundation has been trying to tell us about this problem. They reported 2 different cases back in 2002. Both were morbidly obese patients. One was who had just a routine rotator cuff repair. Patient got a combination of meperidine and Phenergan. It was repeated and found to be in full cardiac arrest, could not be resuscitated. The second patient also had a routine surgery. However, they were put on a continuous PCA, continuous basal infusion along with a PCA, and also had a hypoxic brain death because of hypoxic brain damage because of this. This is a graph that APSF had published that suggests that these patients with obstructive sleep apnea have multiple desaturations over a period of an hour, and sometimes the nurses get tired and turn the alarms off. So even if they have saturation monitors on, it may get turned off either by family or by nurses. And if the patients get some narcotics at any of those time periods, then there can be a sudden arousal failure. And you may never be able to resuscitate the patient. Unlike a non-sleep apnea patient in this graph, you can see who has been receiving opioids can also have desaturations, but it happens over a much more prolonged period of time compared to a sleep apnea patient, where the saturations can just drop quickly after narcotics have been given, and the 1 hourly vital sign time period may not be enough to recognize these patients. We probably need to monitor them much more frequently because their SATs drop very quickly and their CO2 rises very quickly, and they are unarousable in a very short period of time. And you have to remember that these patients are obese patients. They are not pre-oxygenated like our pre-op patients. They are lying supine in bed usually, so they have further reduction in FRC. And while a pre-oxygenated patient just has 3.5 minutes before their SATs will start dropping to below 90%, you can only imagine that you probably don't even have a minute in these patients to have a definitive airway management and save their brain. So the time is very, very essential in these patients. As you've heard from all of today's talks, that these patients' upper airways are highly susceptible to narcotics. they do not have the normal arousal response to both hypoxia and hypercarbia that normal people do. It's very easy for these patients to desaturate to less than 90% in a very short, sometimes in less than a minute, because of the way they are lying down and because of all the additional drugs that they have. And incidence of complications is much higher. It's about 44% in patients with OSA compared to the non-OSA patients. And these complications in joint replacement that Dr. Chung mentioned also are cardiac ischemia, reintubation, and unplanned ICU admission. So it's extremely important to actually do what Dr. Alvarez, Adrian, and Dr. Jan Mulier have both suggested to us, is to avoid opioids. Again, APSF has warned us about the dangers of opioids. This is not even in sleep apnea patients, even in non-sleep apnea, non-obese patients. There is a certain amount of death rate associated with postoperative opioids. There is a certain amount of danger associated with just PCAs, even PCAs, not even just nurse-administered opioid. So it's extremely important to either use regional anesthesia like Adrian suggested, or use a combination of non-sedative drugs like lidocaine, dexmedetomidine. I use ketamine in all of my patients, a sub-anesthetic dose that is 0.2 milligrams per kilo of ketamine before giving any opioid and before incision in 100% of my patients who do not have a contraindication for it. So it's time to actually come up with alternative means of analgesics. So thank you very much for listening and having me.
Thank you very much, Anu. Wonderful lecture. Everything is in line. Everything was okay here. And if you remain connected for the following block, we can participate in the whole discussion with Mike, Jan, Jay, Ashish, myself, Francis. Yes. Would you like to do that?
Yes, I'll stay.
Okay, see you in a while.
Okay.
Bye, thank you.
Bye-bye.
Vamos a hacer el break ahora de media horita, pero les pido por favor que y media, justito, ya estén adentro porque ya están conectados